Hi, this is Julie Lubinsky. I am Associate Director of Digital for the Christopher and Dana Reeve Foundation, and I'd like to welcome you all to today's webcast with Nurse Linda. Linda is a leader and provider of rehabilitation nursing for 40 years. She also writes the interactive Ask a Nurse blog on our online community forum, and we're lucky enough to have her every month here with us taking questions from all of you that are here today. So now I will turn it over to Linda. Hi, Linda.
Hi, Julie, and thank you, and welcome everyone to the Nurse Linda webinar today. It's always nice to have you join us. We are certainly having a better turn in the weather these days, and so that it's getting everybody kind of in the mood to get out, get moving around, and so I hope you feel the same way. Today we have a focus on urinary programs, but we certainly talk about anything and everything as it goes. As you know, this month the blog has been about urinary programs and bladder programs and keeping that system up and running. People always have a lot of questions about bladder programs and bowel programs. And as you all know, when these programs are running smoothly and effectively, life is good. And when they're not working so well, it just seems to complicate everything in our lives. So it's a good idea just to have a review every once in a while and think about your techniques and what you're doing to keep these systems operational and functioning well. So the two systems for eliminating waste from the body, one is bowel and one is bladder. They're both need to be managed, but they need to be managed in different ways. Bowel programs are usually conducted every other day. Some people do them every day. Some people do them every third day. But by and large, most people do a bowel program every other day. They insert a suppository. They use lubricant to make sure that that is inserted well into the bowel, making sure that the suppository is pressed up against the side of the bowel. If you just push the suppository in and it gets in the middle of stool, it does not melt. And when the suppository is not able to sit against the bowel wall, it doesn't stimulate the bowel wall to move. So it's kind of an ineffectual bowel program unless the suppository is against the bowel wall. Then digital stimulation is performed and a bowel movement occurs. Now there's a lot of things that can go into the bowel program as far as your diet, making sure you get enough roughage. If you don't, taking some fiber so that you're sure that you allow your bowels something to move along. Sometimes people think if they don't eat much, then they won't have to do their bowel program as often, and nothing could be further from the truth. You actually want to supply the bowel with something to do. It causes the bowel a lot of distress to not be able to move the substance along. So you want to be able to provide the bowel with some roughage so it gets its workout. It's designed to move things along, and so, let it do its thing. On the other hand, you have the bladder system, which is quite a bit different because you have to empty your bladder several times a day. It's critically important that you do so. Food waste will stack up in the bowel and wait to be expelled. The bowel is flexible. If you have a lot of stool, it will just hold further back in the bowel from the opening, and so it's a pretty rudimentary organ. It's fascinating the way it works, but it's very rudimentary. The bladder you have to be a little more careful with because the bladder is only so big. It can only hold so much fluid. And so there are three openings within the bladder. One is the urethra, which lets the urine out. And then there's two openings at the top of the bladder, which are attached to the ureters. And then those connect right to each kidney on each side of the body. So you have two kidneys. So as the kidneys filter your blood, and blood is circulating through your bodies at all times, so the kidneys are filtering that blood as it circulates, so they never ever stop working. They're filtering waste out of your blood, which is waste that's being removed from the body. It's liquid waste that goes through the kidneys. It goes down the ureters and collects in the bladder until you're ready to remove it. What happens sometimes is if you do not remove it, or if the opening, the sphincter becomes out of sync with the contraction of the bladder muscle, sometimes the urine cannot come out. What happens is it goes the path of least resistance, is up the ureters and then back into the kidneys. Now, the kidneys have no storage capacity. They're a one-way organ. The blood goes through, urine comes out, and gets placed down into the bladder. So whenever you have something backing up into your kidneys, you've got a problem because you're damaging your kidneys. It's very delicate. So you want to be sure that your bladder is emptied properly. You want to make sure that that area stays clean and as sanitary as possible because you don't want to get an infection. Sometimes infection, bacteria is filtered by the kidneys to be removed from the body, which will go through the kidneys and come out through the bladder. If enough bacteria collects within the bladder from the body, you can get an infection. Or if your cathing technique is a little bit lax, you could introduce infection into your bladder. Also, things that you drink or foods that you eat can affect your bladder. Even the food that you eat gets digested through the body, goes through the blood system, and the waste from some of the food is excreted through the kidneys. Certainly fluids that you drink is excreted through the kidneys. So if you drink a lot of sugary drinks, bacteria loves to live off sugar. That's, giving them their prime source of food. So they enjoy that sugar in your bladder as you're trying to release your urine. It will collect, and bacteria love to live on that. Another thing that can affect bacteria in your bladder is movement, and there's been a lot of research lately about how movement helps your whole entire body, just one of which is the bladder, because it keeps things shaken up in your bladder so that bacteria doesn't have the opportunity to clump together, creating an infection. It doesn't have the opportunity to cling on to the wall of the bladder, making it more difficult to get rid of, to process out of the body. So movement is very important. Now, a lot of people say, well, I don't have movement, but it can even be passive movement that will help to keep your bladder stirred. So if you can do passive range of motion on your legs, if you can use your arms to pick up your legs, or even when you do those wheelchair push-ups to release pressure from your skin, that is an opportunity where your bladder is being moved around. When you roll over in bed, you're moving the fluid in your bladder. So any kind of movement is very helpful. Movement also helps the bowels because that helps keep things functioning and moving along. So anytime you move your abdomen or your legs, you're helping your bladder and bowel as well as your skin. So on and on it goes. The urinary system is what is considered a clean system. A lot of people will call it a sterile system. You want to be very careful when you catheterize that you're not introducing infection. You want to keep good hygiene. For men, catheterization is a little bit easier than for women just because of the anatomy. And so sometimes treatments are different. And I know we have some questions that we're going to get into real specifics. So I think we'll go ahead and go with the questions that are in the box here. So let's just go with the first one. And the first one's about hemorrhoids. And as I say, people always want to know questions and answers about their bowel and bladder, but they often don't feel comfortable in asking. Well, this is the place to ask because it's a very important topic, and things happen in life. So hemorrhoids is one of the things that happen. And this is outpouching of that very delicate bowel tissue that is generally contained right inside the end of your bowel. So right at the opening where stool is passed out, there's bowel tissue in there. Tissue inside your body is a little more fragile than the tissue outside on the outside of your body that you normally see. So our skin is very hardy in that it holds everything together. It protects things from bacteria and other kinds of things from entering our body. But the tissues inside are not really often meant to be touched. So when you're doing your digital stimulation, sometimes people can get pretty aggressive with that digital stimulation. Sometimes they maybe don't lubricate their finger well enough, and so it gets kind of rough on that delicate bowel tissue right inside our bowels. So most oftentimes, this is the source of hemorrhoids for people with spinal cord injury, but it's not the only source. So sometimes when people do digital stimulation, they're thinking, well, this is kind of an unpleasant thing, and I want to get this over as quickly as I can, and the more aggressive I am, the more I'm stimulating my bowel to move, and so they get pretty severe with doing their digital stimulation. In actuality, if you do a much slower, longer digital stimulation, but a much more calm type of stimulation, you're going to end up with much more significant stimulation of your bowel to have a stool evacuation. So it's kind of contradictory from what you would normally think about digital stimulation. So some people are very aggressive and they're swirling as hard as they can and they're really making a lot of jerky movements. If you have any kind of spasticity, your bowel is probably also spastic. So we have an expression in nursing, what you see on the outside is most often the way it is on the inside. So if you have a higher level injury and you have a lot of spasms, your bowel is probably spasming also. So if you see leg spasms, you probably have spasms in your bowel and bladder. So the more aggressive and severe digital stimulation you are performing, the more you're triggering that spasm, which is making the bowel work even less because it's in a big contraction. So doing a slow, gentle swirl with your finger is much better. Using a lot of lubricant is also good because that area, the bowel, is moist inside your body, and so you want to not put a dry finger in there, or sometimes people will lubricate just with water. That's not really lubricant. That's providing some hydration. It's not really going to lubricate. So sometimes people can get a little too rough or not have enough lubricant. So, well, gosh, I'm pretty gentle and I use a lot of lubricant. Why on earth do I still have hemorrhoids? Well, another thing is of sitting on the toilet for a long period of time. For people without spinal cord injury, they get hemorrhoids from straining on the toilet. So if you think about digital stimulation as kind of a strain on that lower bowel, and then when you're sitting on the toilet, that allows the bowel opening to kind of stretch, and it kind of stimulates the development of hemorrhoids. And then some people just have a more genetic predisposition to hemorrhoids than others. So it's not always a matter of poor technique. Sometimes it's just a matter of, you just our predisposition is to have hemorrhoids, and so people tend to develop them in all stages of life and all walks of life. Eating a diet that's very soft sometimes leads to hemorrhoids because, as I say, the bowel wants to move things along and it moves roughage best. So if you keep good roughage to your bowel, that's also an important thing. And then also, again, movement is another thing that will help the bowel work, and so that kind of helps reduce your risk of hemorrhoids. So doing some movement will also help. Now, if you do have the unfortunate hemorrhoid problem, there are things that you can do about that. There's Preparation H. There's all kinds of medications that you can use to help shrink hemorrhoids. If you take your lubricated glove finger and reinsert the hemorrhoids back into your bowel. Just push them back up in there. That will keep them moist because remember it's moist inside the bowel and it's dry outside of the bowel. So if you can push them back in there, sometimes they get so bothersome, they can trigger spasms, they can trigger autonomic dysreflexia, it can make the bowel program difficult. Then you would really want to talk to somebody about should you have your hemorrhoids removed or not. That can be a surgical procedure. Sometimes they do what they call the rubber band procedure, which is something similar to a rubber band, but it's placed around the hemorrhoids, which cuts the blood circulation off to the hemorrhoids and they drop off. So talk to your healthcare professional about what is best for you. As you know, I am never really an advocate for surgery unless you weigh the risk and the benefits. So surgery is pretty severe. The positioning and people who have trouble with hemorrhoids from spinal cord injury generally maybe do not want to have elective surgery. So maybe they can use some of these others, cautery kind of procedures or different non-surgical kinds of approaches. So talk to your healthcare professional if it becomes such an issue that you're having bleeding or other symptoms from them. If you have some hemorrhoids, they're small, they're not causing you any trouble, that probably would not be of a benefit to you to have those removed. The risk would certainly outweigh any kind of benefits. But if you're having a lot of trouble from your hemorrhoids, then talk to your healthcare professional about the type of removal that would be helpful. But in the meantime, you can, start with the preparation H and try reinserting the hemorrhoids. Sometimes they'll reduce and shrink on their own over time if they're not too awfully severe. So if you catch them early, you can kind of take care of that. Women who have been pregnant who do not have spinal cord injury often have trouble with hemorrhoids later in life from the pushing of birth, the birth process. So there's all kinds of reasons to get hemorrhoids. Maybe you were, had that situation before you were injured. So these are all kinds of things to think about. So there's another question here about why do so few patients know about the many benefits of suprapubic catheters and the availability of the T-spec placement technique. So suprapubic catheter is a different way of removing urine from your body. This is a surgical procedure where actually a little hole is made in your abdomen just right above your pubis bone. And this little tunnel is created that goes directly from the outside of your body to the bladder. So the advantage to that is if you have a high-pressure bladder where they're really worried about urine backing up into your kidneys, this takes away that complication. A lot of people with higher-level injuries, higher-level spinal cord injuries, will have a suprapubic catheter placed in the rehabilitation process. That is the safest management for some people. For a lot of people, though, it is not necessarily the safest management. Usually people start out with intermittent catheterization if they don't have pressure problems. People will start out with that because what happens is it best mimics the normal action of the bladder. So the bladder collects urine, it stretches. Now, without a spinal cord injury, you would have communication to the brain where you would get, as the bladder fills, it kind of contracts and relaxes real gently. So it's kind of slowly blowing up, kind of like a balloon. When it gets to a certain amount of fill, a message is sent to your bladder or to your brain that says it's time to empty me. And so you'll start looking for a restroom. You'll know about how long you have to get there. It might not be an emergency type of situation. And so you go to the restroom, you open your bladder sphincter, you drain the urine, the bladder sphincter closes, and off you go. It's not really that different with intermittent catheterization. You might not be able to receive that message that you have to go to the bathroom. So you have to monitor either by how much you have taken in, or some people empty their bladder at certain times of the day so that their bladder fills and then empties. Now the intermittent catheter is placed into the bladder for the draining, and then it is removed when that process is empty. So with the suprapubic catheter, a catheter is placed in the bladder through this artificial hole that's been made in the abdomen. So whenever you have a catheter either through the urethra or suprapubic catheter, anytime you have a tube that's permanently placed in your body, you have a higher risk of infection. Now here again we look at risk versus benefit. If you have a high-level injury, if you have a high-pressure bladder, you usually will be offered a suprapubic catheter because the benefit to keeping your pressures in your bladder down so greatly overwhelm the risk of the surgery. If you are a person with a lower-level injury and you do not have a high-pressure bladder, then it does not make a lot of sense to introduce a tube into the abdomen. Now, I will say that sometimes people look at their risk and benefits for any kind of bladder augmentation surgery where the bladder is actually enlarged in size, or if they're thinking about the need for a suprapubic, or if it just is so difficult to catheterize. And in this regard, I'm speaking really directly to women. With men, the way the anatomy is, it's pretty easy to find the urethra. It's accessible. For women, the urethra is more difficult to get to. They might have to completely disrobe their lower body. They might have to lay in bed to catheterize, and so it really becomes an inconvenience. So here again, you have that risk versus the benefits. And so sometimes women will elect to have what's called a Mitrofanov procedure, where a little hole is made in actually the belly button, and usually it's the appendix, which is a little organ that nobody quite knows what to do with. It's just kind of hanging out there in the abdomen, and so that will be removed and made into a little tube that will go from the belly button to and open the other end into the bladder. So it makes it much easier for women to catheterize by putting the tube in through there. The tube is then removed, and then there's no leakage from this because the bladder is lower than the top of the belly button where the urine would come out. So it makes a very efficient process. So some women are very adept at catheterizing on the toilet and using the intermittent catheterization procedure, in which case that is what they should do. But if it turns out that there's problems, then they might, or just difficulties, then they might want to choose to use the Mitrofanov. Now, very rarely do men get the Mitrofanov, and again, that's strictly because their anatomy is so much easier to get to the urethra. However, there are some men who have elected to have it. Sometimes maybe they have become obese and their abdomen is kind of hanging over their penis, so they really have difficulty getting to it. Or some men have a retracted penis, and so it's very difficult to get to that. So there are some cases where men have the Mitrofanov, but it's really a procedure that was actually developed for children to cut down on bladder infections and to make catheterization easier. But a lot of women in the spinal cord injury community are using that. So if you do need a suprapubic catheter because you have a high-pressure bladder, that's an important thing to get. But again, it's looking at those pros and cons, the benefits and the risk to see what is the best thing for you. So not everyone needs a suprapubic catheter, and not everyone should have one. But if you do need one, it's great that it's there to have that. The next person says they have a suprapubic catheter, and they're sanitizing their urine bags and tubings with chlorine bleach followed by a vinegar rinse, and they're seeking a less destructive way of sanitizing rather than using chlorine bleach. So a lot of individuals reuse their urinary elimination products. Some people use the red rubber catheter that they sterilize either by boiling on the stove or by using bleach, and they'll use that catheter several times. It seems like that patients, that's kind of a thing that we used to do years ago. There's still a lot of people who are doing it. They do it well. They do it effectively. You know, if it's not broken, don't try to fix it. If you're doing that and it's working for you, great. It seems like today, with so many people worried about infections, and in more recent years, people have changed to using a new catheter at every single catheterization. There's been a lot of research into this. It doesn't seem to make really a difference if you're correctly sterilizing your catheter or if you're using a different one each time. People who do tend to have more urinary tract infections can usually get these one-time use catheters or self-contained catheters. There's all kinds of different products. So people will sometimes ask to get one of those, but there are different rules by different insurance companies. You have to have so many infections within a certain time period to be able to move up to some of these non-touch type catheters. So most people do what this person is doing, in that they're sanitizing their urine, their night drainage bags and the tubing, or their leg bags and the tubing. And so, yes, the bleach kind of tends to eat away at the construction of these catheter bags. So I am wondering if how much bleach you're using when you clean the bags. So generally we use in the hospital, we teach people for their home to use a hospital wash basin. They're all pretty much the same size. Some are square and some are round, but they're pretty much the size that will hold a leg bag. And we'll usually have people put the chlorine bleach tablespoon into the bag, and then soak the whole bag in water with a tablespoon of chlorine bleach. So that's really not that awfully much of them, that much of chlorine bleach. And then the vinegar rinse, not always do we do that. Usually that you just drain the bag with whatever fluid's in there, and then let the bag dry. A lot of times people will put it in a pillowcase and hang it on the towel rack, because that keeps it clean until it's time to use again. The vinegar rinse is a nice twist. It adds a little extra sanitation, so that's probably a good thing to do. But I'm wondering if you're over using some of that chlorine bleach. And those bags we usually just tell people to use for no more than a month, and then get a new one. Now, you might be using a bag for longer, and if you are and you're not having any problems, that's okay. It's just our rule of thumb that we tell people to change their bags at about a month's time. So that's just something to know. So you just look and see what you're doing, and maybe you're just putting too much bleach in those, and eventually they do just wear out, and so one has to get a new bag. Here we have a patient that's written in that's suffering from intense neuropathic pain, and they're taking gabapentin every 12 hours, but still the pain is just, I guess, unrelenting. What would you like to improve your quality of life because of this neuropathic pain? And neuropathic pain is very, very difficult to treat. There is no one magic cure that's, oh, you have neuropathic pain, well, then you take this pill and it all goes away. It's very individual, because after spinal cord injury, you have some problems with your nerves, but everybody's a little different, and everybody's different in their pain and pain reception. So two people can have the exact same level of injury and have completely different pain scenarios. So it is very specific. If you're taking gabapentin, it doesn't say how much, but every 12 hours you can go up on your gabapentin. That's one thing to do. Some people will take a combination of medications. They'll take the nerve pain, which is gabapentin or Lyrica. You cannot take both of them together. They're basically the same drug with some slightly different formulations. So you should not take those together, but if you're already on the gabapentin, you would probably want to stick with that. If you're already on Lyrica, you would want to stick with that. But you can take some other medications. If you take an antidepressant, which people get very upset, I don't have depression. But there are antidepressants which are taken in a very, very small dose that help pain as well. So some people do a combination of pain medications. So like if you were taking a medication for depression, you might take 150 milligrams. Whereas if you were taking the same medication for nerve pain, you would take 10 milligrams. So you see it's a very different dose. It won't help you with depression if you have it. If you do have depression and you're taking an anti-depression medication, sometimes that also helps your neuropathic pain. So people will want to up their medication. Oh, I've taken this for 2 or 3 days. It's not working. I want something else. The bad thing about these medications is it takes 6 weeks to build up a therapeutic dosage within your blood. So you have to take the medication for 6 weeks before you really hit its peak action. That is a long time to wait when you're having pain. So you might want to talk with your doctor about maybe an increase in gabapentin or adding another medication. Sometimes adding a muscle relaxer helps. Oftentimes it does not. But there are different things that you can do. It seems counterintuitive if you have pain in your legs that moving them would help, but shockingly it does. So if you just very gently do some range of motion on your legs while you're waiting for that medication to kick in, that's extremely helpful as well. Some people will find just laying like a warm washcloth on the leg might help reduce some of the pain if you can, find the right spot. Some people have told me, and this is only anecdotal, I've not seen this tested, it's never in the literature, but some people have said like those muscle pain patches seem to help because it relaxes the muscle, I think, so that the pain isn't perceived so much. There's no evidence of that, but talk with your physician about it first. Don't add anything to your regimen without talking to your physician, even if it's an over-the-counter medication, because when you're taking these pain medications, these patches have medication in them that leach through the skin, and you don't want to overdose or counteract the oral medication that you're taking. So be sure and talk to your physician, but depending on how much gabapentin you're taking, maybe you need to take it every 4 hours instead of every 12 hours. There's all kinds of management, but it does take a long time to get neuropathic pain under control. And then when it is under control, just out of the blue, some days it just starts up again. So you have to take a look again at what you're doing. Some people get on so much so much medication for neuropathic pain that it's really kind of working against itself. And so this doesn't sound like for this person writing in, but sometimes people get on so much different medication for their pain that what really works best is to stop all of it, kind of restock, take a reassessment of where the pain is, and then start over again at lower doses of different kinds of medications, and sometimes that helps. Neuropathic pain is very difficult to treat, but it can be conquered, but you do have to have a lot of patience with that. So, know that you need to wait the 6 weeks if you go up on your gabapentin before you're going to see results from that. Another question about nerve pain, and not surprising because nerve pain, it just affects all kinds of parts of your quality of life. And this person is taking nerve pain medications now, any other kinds of treatments. And again, it's thinking about what kinds of oral medications you can use. They're asking a question about the Cbd oil, which is some oil that has the properties of marijuana in the oil. I hear from patients that take that and just find it to be the miracle cure for them. I hear from the same number of patients who rub the oil on their skin and get no result from it whatsoever. So again, it's very specific to the person, what type of neuropathic pain that they're having and what works for them. So what works for one person is not going to work for another person. There's a question about electric shock. Well, that makes me think of electric shock treatments for depression, and that's not going to help. But the functional electrical stimulation that provides movements to the muscles and nerves, that seems to help people through a lot of pain. Again, it's the movement. So if you are doing passive range of motion, or if you have access to functional electrical stimulation, sometimes that helps relieve the pain too. Not many people have access to functional electrical stimulation. That's those electric bikes that you put some electrodes on your legs and you paddle the bikes. They're very, very expensive, and generally insurance does not cover them. So people are kind of behind the eight ball on that, but I understand that that is going to be changing soon. So we'll have to look forward to that, and that certainly should help. But in the meantime, you can passively do range of motion very gently 3 or 4 times a day, and that seems to help a lot of people. So again, it's trying to find that sweet spot with all those medications to see what would help with that. The next question is if there's any drug for recovery of nerves years after the accident. Well, scientists are certainly working on that. Right now there's a lot of promise with electrical stimulation that's being implanted. It's still in the experimental stage. The Christopher and Dana Reeve Paralysis Foundation is funding the Big Idea, which is a neurotransmitter that is implanted into the spinal column, and so that the messages can jump across the area where the damage is. Jumping is probably not the correct word, but makes those connections. And people are having, in the pre-trials, in the early trials, people are having some remarkable recovery. It's not quite like just getting up and walking like you used to, but it's certainly a step, I guess that's a pun, it's certainly a movement in the right direction where people are getting some really significant recovery, which is improving their life, their quality of life greatly. It's not right now 100% return, but there is a lot of good things. So we're going to be seeing a lot more of that coming out. There's several places around the world where people are doing these studies, and so we're going to be seeing a lot of that coming out. So this is a huge leap ahead in spinal cord injury recovery. And the next question, is there anything to dissolve scar tissue? I'm almost 20 years post-injury C1 and C2. That's a pretty high injury, as you know. And so there's been a lot of study about dissolving scar tissue. There's been a lot of different experiments that have been done. It's still it's still not well defined, let's put it that way. I think probably the best bet that we have going on right now is this implant for the electrical stimulation. Now at C1, C2, that's very high up close to the brain, and I don't know how that would work there, but I think that any step forward, we're learning more and more, and even if somebody does an experiment that's a failure, at least we know that that's not the thing to do, or people will say, well, we did it this way, but if we jiggle this part over here. So there's always things that are being learned. So I think we're making a lot of significant headway in that. The next question is, what causes small red dots underneath the feet? Well, that's a very interesting question. I'm not sure what would cause that. It could be like a heat rash, maybe if you're wearing shoes that don't ventilate well, like plastic shoes, like Crocs, or sometimes athletic shoes are plastic instead of like fabricated material. And so sometimes if air is not allowed to circulate around the feet, it could be something like just a rash. It could be athlete's feet, or it could be some kind of allergy. Sometimes allergies show up in small red dots. So that would be a good question to have somebody look at that and see what that is. It's a curiosity. Sometimes people just get a heat rash that's small red dots, or it could be something else altogether. So that's just, it's probably not something directly related to the spinal cord injury, but it could be something from lack of circulation to those feet. Maybe if you have nylon socks, and again that holds moisture in, so that could be a problem too. The next question is about leg spasticity following open spinal surgery of a dural AV fistula. When it relapses, it's bad. On normal days, it's bearable. Can it be reversed? If I exercise regularly, it appears to get worse by the week. So, by the end of the week. So, leg spasticity is something that happens after a spinal cord injury, and that's what's happened. Is this dural AV fistula was repaired, but apparently there was some damage from the fistula. And sometimes when you repair things, they're just not quite like they were before. And so I'm wondering if your exercise is too rigorous, and maybe just doing some more gentle exercises. I think you'll find that the spasticity will not be worse, but maybe getting better. So sometimes really heavy cardio exercise or weights, sometimes that makes the muscles fatigued, which will make them maybe spasm more, or makes the muscles tired, so they don't know what to do, so they get these spasmy cramps. So I'm thinking maybe a more gentle thing, like if you were doing yoga or swimming or something that's not so traumatic. I don't know what exercises you're doing, but it seems to me like with spasticity, most often the gentler kind of movement is better than the real heavy exercise kind of thing. So that's my thought on that one. Here's a very interesting question about a daughter who's quadriplegic due to SCI from cord compression in her neck. And right now she's sweating profusely when she sleeps. Any bedding material that can keep her ventilated, cool, and dry? That's such a problem for everyone, whether you have a spinal cord injury or not. Sometimes the sweating after spinal cord injury, most people who have spinal cord injury do not sweat from the injury below, but they'll sweat profusely above. And then there's this, every once in a while you get somebody who has a spinal cord injury, and where they shouldn't be sweating, they are sweating profusely. So again, that nervous system is just the craziest thing. It really has a mind of its own, I think, sometimes. So just as soon as you see something and you think, well, this is the rule, you find out here's somebody who doesn't have that rule. So there's a lot of bedding products that are out now that are advertised. Pillows that have like some gel in them, and mattresses with gel in them that are supposed to keep you cool all night. I actually bought one of these pillows that are supposed to keep your head cooler so you sleep better. And so I thought, okay, that's kind of cool. Well, I want to see about that. So I bought one of these pillows, and when you lay your head on it, it is cool for about 15 minutes. And then your body heats up the coolant, and it kind of negates the whole thing. It doesn't get hot or anything like that, but it's no different than a regular pillow after about 15, maybe 30 minutes. I don't know. Maybe I have a really hot head. I don't know. But for me, in about 15 minutes, the pillow was like, well, this isn't cool anymore. So I think probably the best thing to do is to maybe, if she's sweating, it might be because she's too warm, but I have the feeling that you've already checked into that. So using any kind of wicking products, you might want to try one of these coolant mattresses. That would be a huge expense to get a whole new mattress to find out it doesn't work. But there are some mattress overlays that are supposed to be cooling. that you just buy at the store. You don't want to get one that is for reducing temperature. That would be too much coolant. But just, like at the, I think you can even get them like at the Walmart or any of the department-like stores that have sheets. I think they'll have these like coolant bed overlays, and you could try something like that. Now you're going to have to be careful if she has problems with skin, if she does not have sensation, if there's any problems that you might be developing from pressure, because you don't want to put that overlay on top of your pressure dispersing mattress cover. So those bed overlays for pressure reduction can often be quite warm as well. So maybe we should talk to them about making one with a coolant in it as well. So if you don't, if she has sensation and can move, then I would try one of these mattress overlays. If she already has a mattress overlay, you will want to keep that pressure dispersing, and then get some cotton sheets that wick the moisture away. A lot of athletic clothes have this wicking material. Socks have this wicking material. So you can get sheets that have that wicking material too. I imagine the sweating is quite profuse. You might need to use like 2 sheets over, making sure there's no wrinkle in there to prevent pressure breakdown on the skin. Here is another person that has written in that their mother, age 80, is newly and completely paralyzed, C7, belly button down due to having an ischemic stroke. So that's a pretty high level for injury if they're only have problems from the belly button down. So C7 is usually more in the neck area. But since it's a stroke, the problems can appear anywhere within the spinal cord injury. So the question is about life expectancy. Well, for individuals who are non-ventilated, life expectancy is the same as it is for everybody, as for anyone. There is some modification for people who have or who are ventilatory dependent, but at C7 she should not be, and so you can expect her to have a full life expectancy, even though she has a spinal cord injury. Now, you might want to check with her doctor about life expectancy, because we don't know how severe the cause of her stroke. So that would be a diagnosis that might have an effect on life expectancy, but her spinal cord injury actually should not have a issue with that. The next question is, I would like to know if there's anything new for incomplete spinal cord. And yes, I think that all of this information that's coming out that I spoke about these implants, I think that those will eventually be beneficial for incomplete spinal cord. That is just my opinion. And so we'll have to see how that works out. Right now they're being tested in people with complete injury, so we don't know. But again, we're learning so much right now that this will be an interesting outcome to see how it works. So there's a question from a lady who could not be here today, but she's a regular listener, so thank you for that. She has an L1 incomplete injury from a burst fracture, and she's having issues with incontinence. She can sit on the toilet and have nothing happen, and then when she's done, she will have an accident. And she spoke to a physiatrist about it. He suggested Botox. What you're feeling, would you recommend? So Botox is being used a lot for bladder spasms. It is also used if the bladder contracts, but the sphincter contracts at the same time. So when you normally void or go to the bathroom, urinate, your bladder, as your bladder contracts, your sphincter opens to let the urine out. And then when your bladder stops contracting because it's emptied, the sphincter will close, and that's what keeps you dry. And so it's a very complicated neurological process. And so after spinal cord injury, it sometimes gets out of sync. So if you go on the toilet, and this happens so often for people, they go to the toilet, they have no results, and then they get up and like 3 minutes later they're wet. And they're like, well, now wait a minute, I just sat here for 10 minutes, nothing, and now I get up and move, and there it is. So it sounds like that sphincter and the bladder are out of sync. And so using the Botox might help, depending on if you have spasticity in the bladder or the sphincter. Or it could just be that you need to work on that because you're in complete injury. Maybe you just need to work on some bladder training, relaxation to help relax that sphincter. It might be that you might want to start on intermittent catheterization, which is pretty strong choice. There are also medications that can be taken that help coordinate the sphincter and the bladder. So some that help the bladder contract, some that help the sphincter open. There are other medications that help the sphincter tighten and stay closed in case you're having some leaking. And so there's a lot of different options. So it probably would be a good idea. You've got a physiatrist who would know all about these different things, so be sure and check with him. On the other hand, you might also want to ask your physiatrist if there's a urologist around that could do urodynamic testing if your physiatrist does not do that, and then you would know specifically what your issue is. So urodynamic testing, they put a catheter into your bladder. You're awake while all this happens. They put a catheter into your bladder. It has some sensors on it that will sense the pressure in your bladder. It'll sense the pressure of your urethra. And then they start like what is just like regular IV fluid. So they drip some sterile fluid into your bladder and see at what pressure your bladder contracts, at what pressure your sphincter opens or closes. And so you get all of this information about how your bladder is working. And then they can tailor-made just exactly the treatment that will be needed specifically for you. So it's kind of a neat test. It's kind of an embarrassing test because you're laying on a table totally exposed, and then at some point you're asked to bear down like you're going to go to the bathroom. So it's kind of an invasion of privacy, but it's well worth the effort from all the information that you get. On a separate topic, what about Botox for spasms? Well, that is really the treatment that people are using right now. So if you have like leg spasms or spasm in your arm or spasm in your bladder, Botox is also being used for injections into the back of the head for migraine headaches, which they're finding a lot of good results from that because they think what it is the spasm of the muscles in the back of the head, and the Botox keeps that from happening. Now, of course, we all hear about the use of Botox for cosmetic surgery, so taking away those laugh lines. That's a little bitty, tiny amount, but Botox for spasms is injections into the muscles, and that's a larger amount. It's a trial and error to see how much is exactly needed, but a person who does this has a pretty good estimation of how much you'll need. And so it relaxes enough of the muscle. It doesn't relax all the muscle to take away your function, but it relaxes enough of the muscle to kind of cut those spasms. The next question is there any way to know if there's a way to regain muscle after 18 years of improper innervation from nerves? This person had a spinal cord injury 18 years ago, and they're at a Frankel D, so they've got a lot of function going on. But they're having some problems again in that L4, L5, S1, which is controlling the bladder and the bowel. So is there any chance? Well, there's always a chance. I'm trying to look here. It doesn't say specifically what level, but I'm assuming that it's in the lumbar area. When you have these lower injuries, it's kind of the opposite of the upper injuries. The upper injuries tend to produce a lot of spasms. These lumbar and sacral injuries produce a lot of flaccidness. So things are not generally stimulated electronically. But we do have a lot of things going on with a lot of bowel and bladder implants that are being designed specifically for people with lumbar and sacral nerve injuries. And so what they do is they kind of bypass those nerves and supply innervation or supply function to those areas. So there's a lot going on. There's some that are available now. There is a product that's made by the Medtronic people who make a lot of implants. And there are some others that are experimental that are being reviewed. So you can check with your physician and ask about some of those implants. Now, again, that's looking at a surgery. You may not want to do that. Again, look at the risk and benefits, so that would be an issue for you. So would you stimulate? So if the problem now if the problem is higher, if it's in the thoracic area, then you're talking about a completely different option. But at these lower levels, there's some development. It may or may not work for you depending on specifically the type of injury that you have. But you'll never know unless you ask, and you'll never know unless you're tested. So sometimes these lower level injuries, the nerves themselves are just not able to be stimulated. But that doesn't mean that that's you. So be sure and check and, follow through. You'll probably ask your physiatrist or your general practitioner. They'll probably refer you to somebody who looks at these sort of issues, and they'll be able to evaluate you and your situation. Okay, so let's see what else is going on. How would you recommend getting rid of sediment in the urine? I've read that cream of tartar with warm water dissolves it. Does that work? I love this question because this is like on the internet all the time. Taking too much cream of tartar can be really dangerous for your health. So first of all, but there are people that write in on the internet about using cream of tartar for all kinds of bladder kinds of things. So that's just an interesting question. I really like the idea that you're thinking about it, and I'm really appreciating that you're asking about it because you can do a lot of damage also by taking, as I said, too much cream of tartar. So I think that that's a very serious thing to think about. I don't know that you really need to dissolve the sediment in your urine. Everybody has a little bit of sediment in their urine. We don't see it because when you go on the toilet and you urinate into that bowl of water, your urine is mixed in with a whole big bowl, whatever's in that toilet. So you don't really see the sediment. When you have a spinal cord injury and you use a catheter and drain into a bag, you only see that urine product. So it looks much different than what you would see in the toilet. So if you had sediment in the toilet, you would not see it, but if you do in the drainage bag, you do see it. As long as it's not clogging the catheter so you can still get it out, it really doesn't matter if it's there or not. Now, for some people, they see sediment and they automatically think urinary tract infection. That's true for some people, and it's definitely not true for other people. There is a school of thought that the sediment is the calcium that's leaching from the bones because you're not putting weight through your long bones. That has pretty much been discounted, but because people lose a lot of calcium in their bones and get osteoporotic or osteoporosis, and then they see the sediment, they kind of connect the two together. So that's an interesting thing. So I cannot recommend the cream of tartar because I would be afraid of what people might do with that. And there again, I don't know if it really matters if you have that sediment in your urine or not. You have a urine test to look for bacteria. It would tell you if sediment was in there, if you could see it or if you could not see it. And as far as it being there, it's just there. So that's something to think about. If you were up moving around, it probably wouldn't collect so much at one time. And so, again, movement kind of helps swirl things around in there. So that's just an interesting proposition. As a follow-up to that, what about using the standing frame? And so standing frame is good for a lot of things. And most insurance companies, Medicaid, also will pay for a standing frame if you have paralysis. So what a standing frame is a chair that you sit in, but then there's either a hand pump or there is a pump that you can use with your hand. And so a pad is put that blocks your knees. So a pad's put over the front of your knees, and then a pad's put at the back of your hips. So if you think about your knees, if they're to bend, they only bend one way. So the knees only bend to take the feet back. You can put your leg forward, but it's really in a straight line with the upper leg. And the hips, you bend forward as well. That's the way those two joints bend. So once you get those pads in front of you, you press the pump and you start standing. This puts weight on those long bones. It keeps calcium because weight's being put through your bones, so it keeps calcium in your bones. It also will help with spasms because you have weight going through the muscles in your legs. If you get one that has hand motion on it, if you have arm and hand function, you can use it looks like skiing poles, the top of ski poles. And so you can use this and use your hands to swing your legs back and forth, which gives you that range of motion in your hips. So it gives you a little bit of a workout. Again, it gets things stimulated so your bowel and bladder works better. If you have a higher level injury, you might not be able to use the hand function. But and sometimes insurance will only pay for a frame that stands you but does not have this glider function to it. So check into that. But it's a good thing for everybody to use a standing frame because it gives you a different whole impression of your body, because for a lot of people it will be the first time you've seen yourself standing in a long time. So it's very psychologically uplifting and you get a lot of movement, you get a lot of benefits from it. So stand-up frame is a great thing to have if you can get that and if you have some help in having somebody load you into that. So with that, we are at the top of the hour, and I've gone a little over, so I apologize for that. But it's been a great day talking about great subjects, and I'll throw it back to you, Julie.
Great, thank you. I want to thank everybody for joining us, and this is being recorded and will be up on our YouTube channel by the end of the week. So thank you for joining us, and have a great day. Bye.
Ladies and gentlemen, thank you for your participation. This concludes today's conference. You may now disconnect.